This talk is about pattern reversal visual evoked potential interpretation. It is intended for the clinical neurophysiology fellows at Nicklaus Children's Hospital. This talk will be conducted in a question and answer format. The first question is, which of the following is an abnormal P100 parameter? A. Parasietal P100 amplitude of 2 microvolts. B. Sagittal P100 amplitude of 2 microvolts. C. One parasietal P100 less than half the size of the other. D. A P100 with a latency of 100 milliseconds. Stimulation of the right peripheral temporal retina activates the anterior region of the calcarine fissure in the right occipital lobe, producing an electrical field with a vector directed posteriorly and towards the opposite hemisphere. The vector here is represented by the magenta arrow. Stimulation of the right peripheral nasal retina excites the anterior region of the calcarine fissure at the left occipital lobe, producing an electrical field with a vector directed posteriorly and towards the opposite hemisphere. The vector here is represented by the blue arrow. Stimulation of the right central temporal retina excites the posterior region of the calcarine fissure at the right occipital pole, producing an electrical field with a vector directed posteriorly towards the midline. This vector is represented as a blue arrow going directly backwards. Stimulation of the right central nasal retina excites the posterior region of the calcarine fissure at the left occipital pole, producing an electrical field with a vector directed posteriorly towards the midline. This vector is here represented by the blue arrow that just appeared. Scalp electrodes placed in the low mid-occipital region, called, as you know, sagittal electrodes, and with one electrode at each side of it, called parasagittal electrodes, will capture these fields and record P100 waves. The sagittal P100 normally has an amplitude between 3 and 15 microvolts and should be no less than half the size of the one obtained following stimulation of the opposite eye. The sagittal P100 latency normally should not surpass the upper limits of normal for the patient. The actual number varies according to head circumference size and age, and should occur no later than 8 milliseconds than the one obtained following stimulation of the opposite eye. The P100 parasagittal normal parameters are determined by comparing the parameters of the right and the left parasagittals, P100s. The amplitude should be within 2.5 times of the other. If they are not, the smaller one of the two is pathological. So if the right parasagittal has an amplitude of 2 microvolts and the left parasagittal has an amplitude of 6 microvolts, the right parasagittal is abnormal. The P100 parasagittal normal latencies are obtained by comparison. There should not be more than 8 milliseconds difference between the right and the left parasagittal P100s. The most delayed is the one abnormal. Stimulation of the left eye, as shown in this frame, produces P100 with the same parameters. So the answer to this question is B. Next question. Conduction failure and conduction block can be distinguished by visual evoked potentials. A true, B false. This table brings together the different pathologies causing visual pathway abnormalities and the theoretical electrical abnormalities that they would produce. The green illustrates a normal P100, the white waves represents an abnormal one. Lesions in the visual pathway, like any nerve lesion in the limbs, can be classified as demyelinating, axonal, lost, or both. Limb nerve pathology can be further classified electrophysiologically as those producing synchronized slowing, desynchronized slowing, conduction block, and conduction failure. Our method of testing visual pathways, the wide range of normal values, and anatomical constraints limit our ability to arrive to the same conclusions as we can using neurophysiological testing to study peripheral nerves. Theoretically, visual pathway neurophysiological testing should be capable of distinguishing among the demyelinating lesions. Synchronized slowing, which should produce a delay in the peak of P100 without changing its morphology. The synchronized or differential slowing, which produce a P100 delay with low amplitude and long duration. Complete conduction block, which proximal stimulation, the only one possible with VEP, will produce no wave, or partial conduction block, which proximal stimulation, the only possible using visual evoked potential as previously mentioned, will produce low amplitude wave with no change in latency. Theoretically, for a few hours following axonal loss injury, we could see conduction block prior to the axon distal to the interruption dying, but this is not possible with visual evoked potentials. In real life, we see complete conduction failure, which would produce no potential, partial conduction failure that would produce a small P100 with no delay. Yet, with the current diagnostic tool available, anatomical constraint, technical difficulty, and normal variability, as we have previously mentioned, there is significant restriction to our ability to determine a number of the pathologies just listed. So, conduction block cannot be diagnosed. Complete conduction failure cannot be diagnosed with any certainty, since absence of P100 raises the possibility of a technical problem. And the synchronized slowing cannot be diagnosed because mixed demyelinating and axonal loss lesions will produce the same type of pattern. So at this time, when resulting a pattern reversible visual evoked potential, we talk about demyelinating pathology when a significant latency delay occurs with no significant change in amplitude. Axonal loss pathology when a loss of amplitude occurs without a significant delay in P100. And when a drop in amplitude is associated to a delay in P100, we talk about mixed demyelinating axonal loss lesions. Yet, even this distinction is usually not mentioned in most visual evoked potential reports, and the conclusion is usually limited to either a normal or an abnormal study. In case of an abnormal study, the pathology can be localized to the optic nerve, chiasm, and retrochiasmatic region. So the answer to this question is B. Next question. P100 latency reflects the conduction of the fastest visual pathway fibers. A true, B false. Latency measured from the stimulus to the wave onset indicates conduction of the fastest fiber, as they first activate the target neurons that produce the waves. In this case, P100. Although in this frame you can see the onset clearly demarcated by a vertical line, in reality there is no way of knowing where the onset of the positive wave really starts, because it can start anywhere after the previous wave starts dropping. Latency measured from stimulus to wave peak indicates conduction of the bulk of the fibers, the time the maximum number of fibers are arriving to their intended targets. So the answer to this question is B. Next question. Which of the following symbols indicate P100 demyelination? The width of the green thick line indicates the range of normal P100 latencies. The vertical thin line indicates the actual latency. In this example, P100 has occurred beyond the upper limits of normal. Here, the gray wave indicates normal amplitude of P100 and the black line the actual amplitude of P100. So the answer to this question is A. Next question. Which of the following condition is less likely to be distinguished with full pattern visual evoked potentials? A. Bilateral nerve from bilateral retrochiasmatic. B. Right from left retrochiasmatic. C. Left retrochiasmatic from chiasmatic. B. Chiasmatic from bilateral nerve. Once all is said and done, the full pattern reversal VEP, or more often referred to as pattern reversal VEP, report should include unequivocal conclusions about the test, but not about the patient. The study is reported as normal or consistent with right or left optic neuritis or neuropathy, bilateral optic nerve or retrochiasmatic disease. The two conditions cannot be distinguished from each other by visual evoked potentials. Right or left retrochiasmatic disease, chiasmatic disease, or it must be concluded that the study cannot be interpreted. So the answer to this question is A. Next question. Slow conduction is a sign of demyelination. A true, B false. For the rest of this talk, I will change the background color. As you can see, visual evoked potential abnormalities can involve amplitude or velocity, as you know. Velocity abnormality consists of a slow conduction. A slow conduction is the hallmark of demyelinating diseases. So the answer to this question is true. A. How many patterns of pattern reversal visual evoked potential abnormalities can be assigned by determining societal P100 latency? A1, B2, C3, D4. The title of this chart is Visual Evoked Potentials in Demyelinating Diseases. This figure is a miniature version of the figure we already saw just a few minutes ago when answering the first question. The right eye is being tested and the different trajectory of the central and peripheral retina are depicted, as well as the vector of the fields they create. The vectors resulting from right occipital activation are in magenta, those from left occipital activation in dark blue. The fields created by peripheral visual field activation of the anterior calcarine region are directed backwards and towards the opposite side of the brain. The field created by the central visual activated region of the posterior calcarine area produce a vector that goes directly backwards. The little drawing I have added in the form of black cylinders wrapped around by green rectangles indicate normal myelinated axons. Their presence anteriorly indicate normal optic nerve myelination. The horizontal one indicates normal chiasmatic myelination, and the posterior one indicate normal retrochiasmatic myelination. Though with right field stimulation, since all visual pathways utilized to conduct the stimulus to the occipital lobe are normal, there will be a normal electrical field production and their corresponding vector will occur at the appropriate time. Hence, P100 in the sagittal and parasagittal regions will appear at the appropriate time. As I hope you recall, the end of the thick green line to the right indicates the upper limit of normal latency. The thin vertical brown line crossing P100 indicates the actual latency. In this case, the thin line is within the thicker green line, and therefore it is normal in all three P100s. In this figure, I have highlighted the normalcy by introducing double-headed arrows with an olive green star. Notice that the brown line falls inside the thicker green line, as I previously mentioned. This finding indicates that the study of the right eye is normal. A similar situation occurs after left eye stimulation. So the left eye testing is also normal. In the new figure I have just added, notice that the structure pointed by the arrow lacks green coverage. This represents left optic nerve demyelination. In this case, right eye testing produced timely vectors. The timely vectors are represented by the solid color arrows, leading to timely P100s. So the study of the right eye is normal, as will be attested by the normal P100 latency in all the electrodes. If now we look at the left eye testing, that is the eye with the optic nerve demyelination, notice that all vectors here are represented by partially transparent arrows with shape outlines of the same color. We are going to use the transparent arrows to indicate delay vectors. Also notice that all the P100s, that is the sagittal and parasagittal P100s, are delayed to the same degree. In this frame I have added dark red stars. Notice that the double-headed arrows are far apart from each other to indicate significant delay in the parasagittals. So the left eye pattern reversal visual evoked potential is abnormal. In the new figure I have just introduced, the right optic nerve is represented as being significantly demyelinated. And since this is the eye being tested, all the vectors are delayed. Thus, P100s are delayed. So the right eye visual evoked potential test is abnormal. In the same situation, right optic nerve demyelination, when the left eye is tested, all vectors will occur timely, and so will all P100s. So the test would be normal. The newly introduced figure in the fourth column depicts the delay vector resulting from right visual field testing in a patient with bilateral optic nerve disease. That is bilateral demyelinating optic nerve disease. thus it would be abnormal. And the same thing will occur when the left eye is tested, since the left optic nerve is also demyelinated. Those vectors will be delayed, and so will be the P100s arising from them. So the left visual evoked potential study will also be abnormal. In this new example, the right eye is being tested in a patient with bilateral retrochiasmatic demyelinating lesions. The result will be delayed P100s in the sagittal and parasagittal electrodes. Thus, the right visual evoked potential is abnormal. The same situation will occur when testing the left eye. All P100s will be delayed. So the left visual evoked potential will also be abnormal. I have now introduced a new figure representing right retrochiasmatic demyelinating lesions. The vectors that are delayed, represented by the partial transparent arrow, can be easily remembered if we put together the location of the lesion and the direction of the vector normally produced by the occipital cortex following activation. Right occipital lobe activation produces vector directly towards the opposite side and the midline. Thus this vector will be delayed, while the vector produced by activation of the left posterior lobe in blue will be normal. Thus, they will produce a prolonged left parasagittal P100 and a prolonged sagittal P100, but a normal right parasagittal P100. You can see this by noticing the solid and the semi-transparent arrows and their directions. So the right eye visual evoked potential will be abnormal. Left eye testing in the same situation with a right retrochiasmatic lesion will produce the same findings and have the same consequences. And as such, the left eye study will also be abnormal. The new figure I have just introduced depicts a demyelinating lesion in the left retrochiasmatic region and the vector produced by the right eye stimulation. As you can see, represented by the transparent blue arrows, the vector arising from the side of the lesions are delayed, producing a delayed paraspinal P100 in the opposite side to the lesion and a delayed sagittal P100, but not delaying the left parasagittal P100. So the study is also abnormal. The new figure I have just introduced represents a similar lesion but depicting the effect of left eye stimulation. This will produce a delay in right parasagittal and sagittal P100, but the left parasagittal P100 would be normal. So the left eye will be abnormal. The next figure I am introducing depicts chiasmatic demyelinating lesion being tested using right eye stimulation. This produces a delay in left occipital activation since the electrical activity cannot travel across the chiasm to the opposite hemisphere, thus producing delayed right parasagittal P100 and delayed sagittal P100, but normal left parasagittal P100. Thus the right eye VEP is abnormal. Now I am introducing the same pathology, but the eye being tested is the left. Here also the delayed occipital stimulation will be on the opposite side of the stimulus. Notice that the transparent magenta vector being generated arise from the right occipital lobe. The delay in the generation of these vectors arising from the right occipital lobe will produce a delay in the left parasagittal and sagittal P100, but the right parasagittal P100 will be normal. so the left eye testing will also be abnormal. Taking into consideration the state of the societal P100, we can only diagnose 4 conditions. Normal study when both eyes testing are normal. Left optic neuritis when left eye societal P100 is delayed and the right societal P100 is normal. Right optic neuritis when the right eye testing demonstrates a delayed societal P100 and the left eye testing demonstrates a normal societal P100. And a conglomerate of non-localizable conditions when the right and the left societal P100 are delayed. So the answer to this question is D. Next question. How many patterns of pattern reversal visual evoked potential abnormalities can be assigned by determining sagittal and parasagittal P100 latency? A5, B6, C7, D8. Using sagittal P100, we are able to determine 4 patterns of abnormality. In the next few minutes, I will analyze parasagittal findings and use them to further narrow localization. So I will first take away the conclusions arrived by sagittal P100 results only. As you can see in this frame, now I have miniaturized the normal and abnormal symbols so we can better appreciate the changes in the sagittal and parasagittal P100s. I will now start the analysis. In the first column, sagittal and parasagittal P100s are normal. So obviously the study is normal, a conclusion that can be arrived without looking at parasagittal P100 as we have previously mentioned. In the second column, the right sagittal P100 is normal and the left sagittal P100 is abnormal. The abnormality is represented by an increase in the height of the purple rectangle and by the handle of the clock that are past the green area. This is consistent with left optic neuritis. Again, parasagittal P100 need not be analyzed in this situation. The third situation is when the right sagittal is normal and the left sagittal P100 is abnormal. This is consistent with the right optic neuritis. From here on, we must consider parasagittal P100s to further distinguish the different entities. If after right eye stimulation, in addition to right visual evoked potential sagittal P100 being delayed, both right visual evoked potential parasagittal P100s are also delayed, as I have indicated by the little stars and the double-headed arrows in the fourth column, and enlarged here for better viewing, and is also present in the fifth column, and following left stimulation, as you can see, is also present in the fourth and the fifth columns, the sagittal P100 and parasagittal P100 being delayed indicate a certain pathology. These findings that I have now represented in the lower part of the frame under the fourth and the fifth columns by rectangles with little clocks at the borders with their handles past the green area indicating bilateral delayed parasagittal P100 latencies delayed. The only conclusion we can draw in the presence of such finding is that the study is consistent with bilateral nerve or bilateral retrochiasmatic disease. Going to the next column, notice that the double-headed arrows and the stars I have here enlarged in order for us to see what occurs after right eye stimulation. And as you can see, the left parietal P100 is significantly delayed, while the right parietal is within normal limits. Now going to the left eye stimulation, in the same situation, we can see the same thing. That is, that the left parietal is significantly delayed, while the right parietal P100 is not. You can now look at the arrow so you can compare the two sides. The arrow now is pointing to the left and now to the right. I have represented these findings below the sixth column. Notice that the clock on the left is showing delay, while the ones on the right are not showing any delay. And also notice that the vertical size of the rectangle is highest on the left side than on the right side, also indicating a delay. This pattern of parietal P100 is consistent with right retrochiasmatic demyelinating conditions. Now turning our attention to the seventh column, we can see that with right eye stimulation, the right parietal is delayed. This finding, in conjunction with left eye stimulation demonstrating a delayed right parietal with normal left parietal P100, as I have illustrated below, indicates a pattern that is consistent with left retrochiasmatic demyelinating pathology. In the last column, right eye testing demonstrates, in addition to sagittal P100 delay, right parietal delay and normal left parietal P100. This finding, in conjunction with left eye testing demonstrating, in addition to delay sagittal P100, left parietal P100 delay and normal right parietal delay, as illustrated here, indicates chiasmatic disease. So the answer to this question is C. Next question. The presence of the term cross asymmetry in a pattern reversal visual evoked potential report usually indicates A. Bilateral optic nerve lesion, B. Bilateral retrochiasmatic lesion, C. Chiasmatic lesion, D. Technical issues. The hallmark of axon loss is loss of amplitude. In this frame, normal is depicted by taller P100s, the sagittal being the tallest of the P100 and the parasagittal being slightly smaller. Abnormality is depicted as thin lines with hardly any waves. It indicates decrease in amplitude to the point that no potential is recorded. Illustrated at the bottom of the first column, you can see two tall rectangles. Their height indicates normalcy. So this illustration indicates normal sagittal and parasagittal P100 in both eyes. The cream color for the right eye and the purple for the left eye. So the study will be reported as normal. Normal right eye pattern reversal visual evoked potentials, amplitude, and flat left visual evoked potential indicates left optic neuropathy. Flat right eye visual evoked potential and normal left pattern reversal visual evoked potential implicates that the right optic nerve is involved. Bilateral flat pattern reversal visual evoked potential indicates bilateral nerve or bilateral retrochiasmatic pathology. Decreased left parietal P100 amplitude and normal right parietal P100 amplitude with right eye stimulation in conjunction with decreased left parietal P100 amplitude and normal right parietal P100 amplitude with left eye stimulation indicate retrochiasmatic lesion. The retrochiasmatic lesion will be located in the hemisphere that is below the electrode recording the normal parietal P100. In this case, the right hemisphere. Decreased right parietal P100 amplitude and normal left parietal P100 amplitude with right eye stimulation in conjunction with decreased right parietal P100 amplitude and normal left parietal P100 amplitude with left eye stimulation indicates a left retrochiasmatic lesion. The pathology is in the hemisphere below the electrode capturing the normal parietal P100. Decreased right parietal P100 amplitude with normal left parietal P100 amplitude with right eye stimulation in conjunction with decreased left parietal P100 amplitude and normal right parietal P100 amplitude with left eye stimulation indicates chiasmatic disease. This pattern is often referred to as cross asymmetry. So the answer to this question is C. Next question. No identifiable P100 in both eyes may indicate all of the following except A. Bilateral optic nerve lesion, B. Bilateral retrochiasmatic lesion, C. Chiasmatic lesion, D. Technical issues. Bilateral complete optic nerve or retrochiasmatic complete axonal lesion will lead to no identifiable waves. Conduction block due to loss of myelin in a long stretch of fiber long enough to fail to raise the next available notoranvier to threshold when occurring in both optic nerves or both retrochiasmatic regions and is complete will also produce the same effect. Bilateral bad retina when the retina is damaged enough to prevent a stimulation of the nerve and therefore no activation of the nerve fibers in the optic nerve will also produce absence of any recordable wave. The same result may occur with technical issues. In this case, despite the fact that the visual pathways may be normal, no recordable wave will be present. So the answer to this question is C. Next question. Which of the following pathology is inconsistent with pattern reversal visual evoked potential showing a proportional decrease in parietal P100s following right eye stimulation? A. Right optic neuritis, B. Bilateral retrochiasmatic lesion, C. Chiasmatic lesion, D. Bilateral optic neuritis. In this frame I have represented normal pattern reversal visual evoked potentials producing wave of certain sizes, the cidal slightly taller than the parietal since it is created by the activation of the right and left occipital pole after right eye stimulation and also after left eye stimulation, as you can see in this frame. I have also represented right optic pathology producing partial block, which as you can see will produce proportional drop in the sagittal and parasagittal P100 after right eye stimulation. The same will happen with bilateral optic nerve involvement following right optic stimulation, but chiasmatic lesion, whether total or partial, will not produce proportional reduction in parasagittal P100s, since one parasagittal will be much more reduced than the other after testing both eyes. So remember that even when one eye is stimulated in chiasmatic lesion, there will be an asymmetry, as there will be an asymmetry after unilateral retrochiasmatic lesion. The difference is that in chiasmatic lesions, when the opposite side is tested, the asymmetry will change size. So the answer to this question is C. Thank you very much for your attention.